I gather the line down the hall is insane. They must have heard that Drs. Gallagher and Reinhardt were presenting, so certainly not on my account. It really is, though, maybe I'll just take a moment to express gratitude. Jonathon Leipsic, it's really a privilege to be back here in Canada, in La Belle Provence, in Montreal, the home of the greatest hockey team that ever has been. That was for Dr. Rogers, who comes from Boston. But Montreal is a historic city. This is a city that was first, Europeans came 1535, Jacques Cartier, but we're on the traditional unceded territories of the Mohawk Nation. So it's wonderful to welcome you here to Montreal. It's also a great opportunity for me to share gratitude to Heartflow, not only for sponsoring this lunch, but for the constancy of their support of the Society. Going back to 2010, they've been loyal and unconditional supporters of science, innovation, and education through the Society of Cardiac CT. And so I know I speak for the entire Society when I express personal gratitude to Heartflow for sponsoring this symposium and for being such loyal supporters of the Society over the last 15 years. So it is my job to frame this conversation. It's a real privilege to be welcoming two dear friends, Dr. Sarah Reinhardt. Sarah is really an amazing clinical and preventive cardiologist and imager. Her work goes back to early formative days in atherosclerosis characterization, her work that she did over in Piedmont, in Atlanta. She's gone back to her home state of West Virginia, for which I'm humbled by her dedication to really try to transform the health outcomes for patients in West Virginia and Charleston. And she's really been a thought leader not only in the integration of CT in prevention, but also of atherosclerosis quantification and characterization, as we saw in the presentation earlier by Dr. McCarthy on the DECIDE registry, which she'll share some thoughts on. And then a dear friend and colleague, Dr. Michael Gallagher, who helps lead the Corewell Health System, the Beaumont Cardiac CT program in Michigan. As we know, Dr. Gil Raff helped form that program. That's been a program that has been at the bedrock very much of the field of cardiac CT. And I've learned so much from Michael over the years. So I'm sensitive to the fact there's still people in line, but I do want to be respectful of time and make sure that we have an opportunity for questions. Without further ado, I'm going to try and share with you some of the lessons that I've gleaned from cardiac CT over the last 20 years. Many of these lessons have been gleaned in partnership with so many in this room, and in fact, not only in partnership, but frankly, from so many in this room. This is who I am professionally. I do have disclosures. I run a CT core lab that supports a lot of structural heart disease trials for which I take no compensation. But I do proudly give advice to Heartflow around research and education. That's obviously very salient to this symposium since the lunch has been provided by Heartflow. So you didn't come here to this lunch and you didn't come to Canada and to Montreal to hear this, but I think we do need to ground it in what we've learned as it relates to cardiac CT over the last 20 years. And that is that CT is a unique tool that allows us to non-invasively characterize and identify atherosclerosis. For the junior people in this room, you take this as we would say, Dr. Desjardins en français, sous-entendu, already understood, right? But this wasn't understood 20 years ago. If I did a CT 20 years ago and I spoke to Dr. Gallagher and he asked me, well, does this patient have a stenosis? And I would say there's no stenosis, but the patient has plaque. Dr. Gallagher may have been smarter than most of the cardiologists that I worked with, but traditionally what they would tell me was, well, his LDL is okay, so it doesn't really matter. Of course, now, 20 years on, we've learned that the presence of atherosclerosis, both on the presence and extent and severity, connote a dose-response relationship with adverse cardiovascular events. And it's for that reason that Drs. Blankstein and Curry iterated the CAD-RADS document, highlighting that when we visually interpret CT, we shouldn't just simply say whether there is or isn't a stenosis. We should comment about the number of segments of plaque or the good old-fashioned calcium score, which is a surrogate measure of atherosclerosis, allowing us to provide a semi-quantitative measure of whether or not the plaque is mild, moderate, severe, or extensive. Now, you may say, why do we do this? Well, we've seen consistently over the last 2 decades that the extent and severity visually of plaque, whether it's the segment involvement score that was shared earlier today, work from Marcio Bittencourt and Ron Blankstein, published over a decade ago, and Circ Imaging, exhibited a dose-response relationship with MACE, and also the very beautiful work, like so much of the great work in cardiac CT from the West Danish Heart Registry. I know we have Scandinavia Presents tomorrow afternoon. This is work looking at the relationship between the calcium score and downstream risk, and highlight that patients who have a higher burden of calcium are more likely to have an adverse event independent of stenosis severity. So many of you may be saying, well, Jonathan, you've just shown us that really visually I can adjudicate the number of segments, and with a crude calcium score, I get a fairly good measure of atherosclerosis. And so you may posit then, why would we really need to quantify the overall extent of atherosclerosis? Why would we need to characterize the percentage of calcified and non-calcified plaque? Well, I think there are a number of reasons why that may be the case. I think to start, while visual assessment of plaque is important, it obviously doesn't allow us to really discern whether a segment has a minimal amount of plaque or a moderate amount of plaque or a significant amount of plaque. Or even the calcium score. We know that the calcium score is the tip of the iceberg as it relates to the overall atherosclerotic burden, but it falls down certainly in an ethnically diverse population, as we saw recently from the CAC consortium published about 2 months ago in JACC Imaging, but it also falls down on those patients who are already statin or no longer statin naive, patients who've been on statin therapy. If you have a calcium score of 100 and the patient has been on a statin for 10 years, is that actually a significant amount of plaque, or is that disproportionately calcified owing to the presence of or the exposure to statin for a decade? Another key reason why we would want to consider quantitation of plaque is because we know, as we saw very elegantly earlier in the presentation from Dr. Agatston, that plaque progression is a needed step for myocardial infarction. There's a false understanding that somehow mild lesions cause MI tomorrow. Mild lesions, of course, don't cause MI tomorrow. Mild lesions cause an MI later on, but what they need to have before the MI is, of course, progression of both the focality of plaque and probably the totality of atherosclerosis. So if we assume that progression is needed prior to myocardial infarction, then we really need a tool that allows us to not only characterize the amount of plaque and the components of plaque, how much is calcified and how much is not calcified, but also to use CT to actually understand the overall efficacy of medical therapy. Is medical therapy being effective not only in reducing LDL, but in preventing the progression not only of the focality of disease, the focality of the physiological pressure loss, but also the totality of atherosclerosis, stabilization, whether it's conversion to calcium, and a reduction in the overall rate of plaque progression. The challenge, of course, is that calcium scoring cannot do this. We've known this for some time, that calcium can go up and it can outstrip the rate of plaque progression. That would be protective. That would be typically what we see on medical therapy. On the other hand, we can see calcium go up and it can be going up at a rate lower than the overall rate of plaque progression, which would obviously be quite bad. And you can't discriminate the two with a good old-fashioned calcium score. So we all hold great hope for the integration of AI to allow us to routinely integrate quantitative plaque measures, allowing us to assess the total plaque burden, the percentage of calcified plaque, and the percentage of non-calcified plaque. As I frame the discussion, which will pivot quickly to the DECIDE registry and then also clinical cases, I did want to share this one slide that I think is perhaps one of the most important slides that's ever been shared with me in my practice. And that is for myself as a technophile to really understand the evidence requirements to adopt a clinical tool. And that evidence is often, from my clinical cardiologist, very much focused on the higher levels of this step ladder. You know, does the tool predict risk? Does the tool modify my clinical decision? Unfortunately, in my training in radiology, we often ignored those higher levels, but often my clinical cardiology colleagues will ignore the bottom levels. Is it technically feasible? Is it reproducible? And is it accurate? Because it seems very mundane. But fundamentally, friends, if you do not have a tool that you can trust, if you do not have a tool that is reproducible, if you do not have a tool that is concordant with the intravascular gold standard, you do not have a tool that can inform your practice. Sure, will a mild, moderate, or severe amount of plaque predict incident MI? Probably, but so can my eye. But if I want to track treatment response, I need a tool that is in fact stable and reproducible. To that end, the tool that you'll hear from my colleagues about, both clinically and from the DECIDE registry, was validated by Jagat Narula in the largest multi-center international study comparing AI-based quantitative plaque versus intravascular ultrasound. Importantly, prospective, independent core lab, Akiko Mahara at CRF, global thought leader in intravascular ultrasound with independent correlation of quantitative plaque using CT. Total plaque volume, calcified plaque volume, non-calcified plaque volume, all showing a high concordance with the intravascular gold standard. This does not automatically hold true for all tools. We heard nicely from Dr. Day earlier, her really seminal work that was done and published in Lancet Digital Health out of Cedars-Sinai. She's taken the time to validate versus IVUS. But I think as we look at new tools, we really need to understand their clinical validation as it relates to their diagnostic performance, not as it relates to the presence or absence of plaque and an AUC measure, in other words, the ability to identify plaque or not. That is a very crude assessment of diagnostic performance, but rather what we really need to know, if you're telling me that you're quantifying plaque, how does it correlate with intravascular imaging? And you can appreciate that these tools are not consistent, with some tools exhibiting correlation coefficients on the order of 0.5, also suggesting that they may be perhaps picking up disease that is not present, not just visually not present, but may not be present as it relates to intravascular ultrasound. We also need tools that iterate based on the blood pool attenuation and KV. This is very thoughtful work done by Hide Takagi from the Paradigm Registry a number of years ago when he was with us in Vancouver, highlighting that by simply changing the KV or the blood pool attenuation, you can drastically change the components of atherosclerosis. This is shocking, the differences this can make. So it is very important that the tools that we use do not use fixed Hounsfield unit thresholds, which some tools unfortunately do. Because if you use fixed Hounsfield unit thresholds, I could have Dr. Reinhardt come to me and say, Jonathan, I'm sending you a patient who was imaged a few years ago, and I really want to motivate him to continue on his medicine. And I'll say, okay, wonderful. You know what I'll do? I'll increase the KV, and it will decrease the calcium, and it will increase the non-calcified plaque, and you can tell him that he really needs to adhere to his medical therapy simply by changing the KV. This would not be helpful, though. So we do need tools that actually iterate based on the blood pool attenuation, and the tool that we're discussing today does that. We also need to contextualize the amount of plaque in the context of patients. Work by George Seamus from Lausanne, unfortunately couldn't join us, will be shared tomorrow. Over 270,000 patient nomographic data stratified by age and sex. Why is this important? Well, obviously we talk about staging 250, 500, 750 millimeters cubed of plaque. Those are important staging thresholds. But if I have a 42-year-old woman, I'm going to be waiting a long time to identify a 42-year-old woman with 750 millimeters cubed of plaque. But the presence of any meaningful plaque in a 42-year-old woman should be considered premature. So contextualizing the amount of plaque by age and sex is, I think, very important. And then finally, we need, of course, to better understand how these tools inform prognosis. This is work from Dr. Fairbairn from Liverpool Heart and Chest. This is a sub-analysis of the fish and chips work that he published in Nature Medicine. I don't publish in such journals, but I guess he stooped to this level. I'm joking, he's in this room. Congratulations, Tim, on the totality of your work. But this work highlights that the quantitative atherosclerosis burden was prognostically important, not just based on very large gaps in the threshold, but rather even modest amounts of plaque were predictive of risk. Ultimately, though, what I've learned from my clinical colleagues is that the opportunities for the prevention cardiologists are great, but the challenges are equally great. As Dr. Blankstein highlighted earlier, in preventive cardiology 20 years ago, the question was, should you take a statin or not take a statin? Now you have a richness of opportunities to up-titrate medical therapy, and I think we as imagers have a tremendous opportunity if we have an accurate, stable, and clinically useful AI-based tool to actually help support decisions around complex up-titration or down-titration of medical management. So I will stop there because I'm going to pivot to Dr. Reinhardt, and then we'll go into some clinical cases. Thank you for your attention.
Thank you so much for that wonderful background on the 20 years of atherosclerosis. So it's my pleasure to go over the background outcomes and clinical insights from the DECIDE registry, and Dr. McCarthy did an excellent presentation this morning, so some of this will highlight what he talked about as well. So my disclosures are as follows. One of the things that we've learned over the course of cardiovascular CT is that non-obstructive disease really matters. We've seen that in the Scott Hart trial across both genders, but also across the CONFIRM registry, where we know that non-obstructive disease is prognostically important. And this was key to evidence that helped elevate coronary CT to a Class 1A indication for evaluation of symptomatic patients. And part of the reason is we started preventive medications at an earlier stage, but what this shows us is the majority of the patients who are actually receiving that preventive medication have more obstructive disease greater than 50%. And again, one of the slides that Dr. McCarthy showed this morning really highlights in his group that a third of intermediate to high-risk patients with non-obstructive disease are actually not on statin therapy. And again, the chest pain guidelines highlight more preventive therapy across the entire spectrum of disease when they reclassified coronary artery disease. But it's not just about non-obstructive disease. We actually are not good at treating our highest risk patients. And this is from the Gould Registry and the Santorini registries. These are clinically symptomatic patients who have had events, whether it be strokes or patients who needed revascularization, where they monitored their lipid levels. And what they found is that 2/3 of our highest risk patients still have an LDL of more than 70. In the Santorini registry, which is more Europe, again, 73% of patients were missing their LDL goals in our highest risk patients. And they felt like this was because we had inadequate risk classification, but also underutilization of the amazing combination therapies that we have available today. So across the entire spectrum, we have a challenge of how can we be more aggressive and promote clinical action for our physicians and for patients alike. So this pivots to how can we use a tool to help enhance both clinical performance from the physician side, but also adherence from a patient perspective. So when we looked at this, we thought plaque analysis may be key to this. So what we found is that we looked at a coronary CT, and then 90 days afterwards, we looked at any alteration in patient management after the plaque analysis was made available to our patients. This could have been treatment modification, additional laboratory testing, referral to a specialist, or performance of other imaging modalities. So there are multiple arms to this study. We're just going to focus on one, which is our primary endpoint. And again, we tried to separate action from the coronary CT from the plaque analysis. So we had over 900 patients who were symptomatic, who had a CT performed, and we looked at their treatment and medication for the first 90 days. Then we had the plaque analysis available, and then we monitored any additional treatment changes that were made in days 90 through 180. And hopefully we'll downstream look at outcomes as well as in addition to the changes in management. So when we look at the DECIDE registry framework, we're looking at different staging, and we taught all of our physicians who were on board in this registry that we looked at different stages for different plaque volumes, and we had LDL thresholds, non-HDL and ApoB thresholds for each stage of plaque volume. And we taught them that if they were over the 50th percentile or had risk enhancers, that you could advance the stage to the next, such as if they were mild but they were diabetic, were over the 50th percentile, you could advance to the moderate stage of therapy. And then what we did is we highlighted all of the cardiovascular medications with proven cardiovascular benefit. But we let it up to the physicians to decide what they were going to do. We didn't mandate treatment. So all of this is real-world data on how we were teaching them how to use it, but how they chose to implement what we were suggesting based off of the plaque analysis. So Jonathon showed this slide earlier. So what we do know is that fish and chips actually has shown and validated our plaque volume. So for each plaque volume that is over 100, you actually see an increase in cardiovascular events. So this gives further validation to the expert consensus algorithm that I just showed you. So when we look at the baseline characteristics of our patients, they are very diverse patients, but 50% of them were women, which is tremendous in a registry of this type. Most of them had symptoms of typical angina as well. When we look at the baseline CT characteristics, one of the things I want to highlight is over 50% of these patients had non-obstructive disease. And there was a high total plaque volume with an average of 321 millimeters cubed. But what you can see is it's also very broad distribution of plaque burden throughout each of the stages, with 25% of patients having mild plaque burden, 27% of patients having moderate plaque burden, 16% with severe, and 32% with extensive plaque burden. What were our results? 51% of our participants had a change of their clinical management, with most of them receiving treatment escalation of 36% and 14% having new lab orders. This could be because patients were looking, or clinicians were looking for residual risk factors like Lp(a) or trying to see if their patients were truly at goal. There was some less than 1% de-escalation of therapy, and less than 1% use of other imaging. 49% of patients had no change in their therapy. Yet when we look across the subgroups, what you're going to see is substantial alterations in management across all subgroups, whether it's their age, their gender, or whether it's their risk factors, with the most predominant changes with those with obstructive disease, hypertension, and hyperlipidemia. But the thing that is so striking to me with this is that despite the knowledge after the coronary CT, knowing their clinical risk factors, it's the plaque analysis that drove clinical action in a lot of these patients. So again, what we see is across escalating stages of plaque volume or stages of DECIDE plaque staging. Remember, we could advance the stage if they had a percentile. You see further advanced changes in their medical therapy. Now, one of the feedback that I always got as I was training sites on the algorithm was, why are we doing this in severe patients or patients with severe stenosis? What this shows is that despite having severe disease and knowing that we need to be very aggressive with our medical therapy, the plaque analysis was used to titrate medications in those with the most advanced burden of coronary atherosclerosis, further demonstrating to us that artificial intelligence with plaque analysis based on a disease that we can see, such as coronary atherosclerosis, can clearly impact clinicians' actions. When we look at the changes in medical therapy, again, the majority of the changes were addition or intensification of lipid therapy, but we also saw about 10% titration of anti-anginal therapies. And one of the things that excites me is 10.8% of patients actually had GLP-1 agonist or SGLT2 inhibitors. Why is this important? Just like we need to go beyond CT stenosis and looking at the lumen to looking at plaque, we need to go beyond looking at just the lipid values to looking at cardiovascular metabolic disease and treating the entire spectrum that contributes to the development of coronary atherosclerosis. What we saw was a negative 18.7 milligram deciliter drop in LDL compared to 3 milligrams in the people who had no change in their medical therapy. What does this clinically imply? From this LDL reduction, you could extrapolate that one could expect a decrease in cardiac risk of nearly 15%. And if we continue to titrate medical therapy and actually achieve those target LDLs, non-HDLs, and ApoBs that we proposed, that could be even more significant downstream. So one of the things I like to do is lessons learned from DECIDE. And what we found is that there is a lot of clinical inertia with our clinical practitioners. And when we looked at the GOLD registry, 80% of them, the physicians, believed in high-intensity statins. 95% believed in targeting LDLs. Yet when you looked over the course of time of 2 years, it's quite striking that 2/3 of patients did not achieve their target LDL, and only 17% actually had titration of therapy. So this shows that we have to motivate clinicians in a different way, and plaque analysis may be able to help with this. So how can our methodology, our treatment strategy help? It helps to develop a plan, a proactive preventive care that is individualized to the patient. It helps inform our patients in a very simple manner where we can show the patients their disease and LDL targets, simplify that discussion, but make it meaningful for the patient. It helps us initiate. How can we drive ordering laboratory tests and utilize those combinations of therapy for those improved outcomes? But also the personalized care that we can do, because we're looking at patient-derived plaque volumes, personalized disease burden that we can get appropriate, specific LDL goals. Again, the Gold Registry gave us insight into patients' reality. They're really unaware of if they have coronary artery disease, especially if it's not obstructive in some cases. They may not understand their cardiovascular risk. They don't understand why they're on lipid-lowering therapy. They don't know their LDL goal in the majority of patients or what their treatment goal is. But with this DECIDE algorithm, number one, they can see their images, and seeing is believing, and they can understand their condition more meaningful, and we can say to them, this is your LDL today, this is what your target is. And that will help with adherence downstream. But it also helps us to understand by showing the disease burden. You need these medications to halt that disease in its process, stabilize that plaque so it doesn't grow further. And again, helping them understand these are goals that are specific to you, because traditional paradigms of our risk factors are clearly not working on a personalized manner. So what this implies and highlights is there's an education gap for patients that if we address it with such things as coronary plaque analysis, we can improve this shared decision-making as well as treatment adherence. So another thing that I hear is different patients or physicians may respond differently when I'm teaching them about the plaque algorithm. So the first one probably gets the most benefit from the plaque analysis. I target LDLs less than 100. Well, not all of us can keep up to date. Maybe it's a primary care physician or a subspecialist, but we can use this tool to help educate people what the true LDL goals are, especially as the guidelines continue to change. I see a lot of physicians who say, I already use high-intensity statins and am aggressive with every patient. But the fact is, some of those patients get lost to follow-up, and their PCPs may end up managing their disease process. But we're obviously not getting these follow-up labs or titrating over time, especially if they're already on a high-intensity statin. So this reinforces the combination of therapies, and if they do get lost to follow-up, their PCPs will see that report and still see what those LDL targets are. Now, we may have lipid specialists in the room who are aggressive and have patients on multiple meds, but as we use more meds, sometimes I have a patient who's on 4 different cholesterol medications who has familial hyperlipidemia, and they're like, do I really need another drug? So looking at these subcomponents of plaque, looking at plaque progression, is the plaque stabilizing or is it still growing on that therapy, can help provide the physician information as well as the patient. Yes, you're still growing plaque, you need these more advanced therapies, and it's justification for these niche medications which may be at a very high cost. So when we look at DECIDE, number one, I want you to remember 50% of patients received a refined management plan. 45% of these had non-obstructive disease, and with the LDL reduction in those we could follow that had 18.7 milligrams per deciliter, we could project about a 15% decrease in risk of events. All of this is in line with the Lancet Commission, which wants us to change or pivot from late-stage event management and reactive care to early detection of plaque and proactive risk reduction. With this plaque analysis tool and the results we've shown today, this is a reality that we can take home to our patients. And Michael Gallagher is going to show us how he implements this in 2 of his patients.
Great. Thank you, Sarah, and thank you to Jonathon and Sarah and the Heartflow team for inviting me to be part of this presentation today. It's a privilege to be with you all. Do you have my slides up
Yeah,
there?
I think you
Next
just
slide,
go
sorry
next.
about that. Okay, great. So the title of my talk is How AI Plaque Analysis Has Changed My Management Strategy. And so you've heard a lot from Jonathon and Sarah about the great things, the great research with plaque analysis and some exciting data that we've all learned about this week. I want to try to bring that to life for you to share clinical context of a patient I saw in the outpatient setting as well as a patient in the emergency department. So we'll start off with case number one. Case number one is a 52-year-old male who I saw in my office with his wife for assessment of his chest pain. He had a history of hyperlipidemia and was on a low dose of a low-intensity statin, simvastatin, 20 milligrams a day. His father had a bypass at 62. He was on losartan for his blood pressure, which wasn't very well managed. He described his chest pain that occurred sometimes at rest, but often with exertion, often when he played hockey. And he came to me because that frequency of the pain playing hockey had increased. Importantly, he'd had a stress echo in the previous 2 years that was negative. You can see his blood pressure was not very well controlled, and his cholesterol was 255 with an LDL of 139. His EKG was normal, and his A1C was 5.6%. So I, like probably many of you in the room, turned to a CT first diagnostic pathway in this situation. And so that's what we did. We performed his cardiac CT that you can see here. And if you take a look at his CT, he's got an awful lot of plaque for a 52-year-old male with extensive non-calcified plaque. His lumen, it looked like about a greater than 70% stenosis and focal calcified plaque as well throughout that proximal to mid-LAD. His right coronary had mild disease as shown. And so we sent this data off, as I'm sure most of you do as well, for physiology. And you can see that the F.R.C.P.C was really convincingly negative. There was no suggestion of lesion-specific ischemia. We opted to treat him medically for this LAD stenosis. And so we classified him as a CAD-RADS 4A with an F.R.C.P.C value of 0.9. And his plaque burden we estimated visually as a P2 to P3. Now, I also want to share with you that we are able now to send this plaque off for CT off for plaque assessment, as you can see here. And you can see this beautiful depiction of the 3D model of the degree of plaque. And you can interrogate this lesion down the course of the left main LAD and look at the degree and burden of plaque. You can calculate your plaque score visually and look at the region that the cursor is highlighting throughout this user interface tool. And what I want to share with you is his whole overall plaque score was 619 cubic millimeters. The majority of that was non-calcified plaque that you can see here on this PDF. And so a non-calcified plaque score of 526, you can beautifully see the correlation of the short axis plaque together with this longitudinal plaque overlay that the Heartflow model offers. And if we look at this data together, the CT, the physiology, the plaque, we opted to treat him medically, to aggressively manage his what we felt was non-cardiac chest pain, and to not proceed with invasive coronary angiography. However, as you know, things can change, and the patient presented 6 weeks later to the emergency department, again with chest pain, after playing hockey again, and found himself sitting in the ER on IV heparin on a Sunday night. And so the next morning, we opted to take him to the cath lab, as I suspect many of you would as well in that scenario. And you can see nicely in the bottom left that his angiography showed just mild to moderate disease in the LAD with a 40 to 50% stenosis. And we are reassured to see that the invasive adenosine hyperemic FFR values correlated very nicely with our FFRCT, as we typically see. So a very nice match with physiology. But what I also want to share with you is if you look at the bottom right panel, we had a wire down his LAD. My partner, Rob Safian, did this case. And you could now measure the degree of intravascular ultrasound plaque, both non-calcified plaque, calcified plaque, and compare that to the Heartflow CT plaque assessment. And you can see this beautiful correlation here with the CT plaque assessment in the middle, the IVUS plaque assessment on the top. And as we've learned from Jonathon's talk just a half an hour ago, when we know from the correlation between the degree of calcified plaque, as shown here in my patient's example on IVUS, and non-calcified plaque shown by the yellow arrows, it matches very nicely with the CT plaque assessment. And that, of course, was also shown in a much bigger patient cohort, 230-some patients in the REVEAL plaque study shown here. So this correlation coefficient, 0.91, we've certainly seen that clinically, and we do this often in our care of patients. And so what I also want to share with you is that now in our reports, we, as you all no doubt do with CAD-RADS, specify the stenosis severity based upon CAD-RADS, but we also take the opportunity to classify our plaque burden. And what we tend to do is use our plaque staging system, P1 through P4, and we correlate that with objective measures of plaque now. So plaque volumes, plaque degree, plaque burden is how we decided to characterize P1 through P4 burdens. We also put the Heartflow percentile and total plaque burden assessment as shown there. So this is embedded into all of our EPIC reports. And as you already learned from Jonathon as well, our task is to define the degree of plaque on our reports with a plaque staging model, and that's recommended to do that with a visual assessment, but I too have a really hard time visually, even following this table, to know where to classify the plaque scoring system at times. And so it's really nice to now be able to, in this particular case, 619 cubic millimeters, is a P3 between 250 and 750 cubic millimeters. It's a very accurate and reproducible way for us to stage plaque, and that's what we've taken on in our health system to report plaque. Now, I also want to share the exciting DECIDE data. Sarah spent a lot of time sharing with you the wonderful results of DECIDE. And so as you see in this group here in the middle with significant plaque, 250 to 750 cubic millimeters, you've seen the treatment recommendations that are part of DECIDE. And unfortunately, with our patient who was not well controlled from a cholesterol or blood pressure standpoint, I'm proud to say that we were able to convert him from a low-dose, low-intensity statin, Simva 20, and losartan 50 for his blood pressure before the CT. And after the CT, I'm sure many of you do the same. You see that degree of plaque. He's 52. We switched him over to a high-intensity statin, maximum dose for rosuvastatin, ezetimibe 10 milligrams, a PCSK9 inhibitor. We maximized his antihypertensive therapy. We added aspirin. We checked more data, NMR profile, lipoprotein A levels. And I really saw in this patient, as I'm sure many of you do as well, it really mattered to him. He began a new fitness program. He lost 15 pounds. Behavior and lifestyle change when patients see this degree of plaque. So a nice example of how the degree of plaque really helped us maximize therapy, and also how the plaque assessment correlated very nicely with IVUS, and the physiology in the lab correlated very well with physiology based upon F.R.C.P.C. So that's case number one. I think in the next 3 or 4 minutes, I'll go through case number two, which is a shift to the emergency department. And I don't know how many of you all are using CT in the ER. It's certainly our mainstay. This is a 54-year-old who presented to the emergency department with chest pain. And this patient came in on Thanksgiving Day with chest pain after jogging. He typically jogs 2 to 3 times a week. He described it as mild intermittent chest pressure, sometimes shortness of breath. And importantly, he had a history of hyperlipidemia as well, with an LDL of 160. His dad had a bypass or PCI at 53 years of age, and a calcium score was done a year ago, which fell at the 82nd percentile. So he was put on a low dose of atorvastatin based upon that calcium score. He came through the ER with chest pain, and so he had a negative EKG, not normal, but a negative EKG, some nonspecific changes, 2 high sensitivity troponins that were negative, and his heart score was 4. So we had an intermediate heart score. And I don't know how many of you all are doing this in the ER, but there's really highly effective tests to perform a cardiac CT in this situation. We performed a cardiac CT as shown here with diffuse disease in the LED and diagonal. And as you know from the guidelines from Martha Galati and the team, now 3 or 4 years old, he's in an intermediate risk category. CT is an excellent test to turn to. We were able to look at the CT, gauge the degree of stenosis. And if you look at the Heartflow roadmap assessment as well, and you look at the degree of stenosis, they classified as 50 to or greater than 70% in the LED and diagonal. That agreed very much with our interpretation. You can see he also had some areas of 50 to 70% stenosis. But what's really important to recognize now is that we can also overlay the plaque assessment as we did here and look at the degree of plaque, the eccentricity of the plaque, the amount of non-calcified plaque, the amount of low attenuation or higher risk plaque in this patient in the emergency department. And so when we look at this in a more global fashion, look at the 3-dimensional plaque assessment, beautiful tool that allows us to now look at the spatial relationship of the plaque. the degree of non-calcified plaque. And if you compare the visual assessment to the AI assessment by Heartflow, and then if you look in the region here, well, first of all, I can get a plaque score that's in this case over 700 cubic millimeters with low attenuation plaque, 8% in this patient in the emergency department. And now if I look at that area in the purple box and I navigate through that on the plaque interactive tool, you can see the degree of non-calcified plaque and calcified plaque, and you can integrate all that information together with, of course, the physiology. So we've got his FFRCT assessment that shows a delta FFRCT across the lesion of 0.18 in a further down LED FFRCT value of 0.77. So you have all this data together to look at in our patients in the emergency department with extensive plaque, delta FFRCT positive, nominal value positive, low attenuation plaque characteristics a concern, and we bring all this data together to better inform our decision. So we brought the patient to the cath lab, as you'd expect. I want to share with you what the cath lab findings showed. You can see that the invasive assessment had an invasive hyperemic FFR of 0.73, correlated beautifully with our FFRCT. But we also chose to put, of course, a wire down the artery to put a stent in. And so before we did that, our team did an intravascular ultrasound and demonstrated this extensive bulky plaque by IVUS in the LAD, but it allowed our interventionalists to really understand, the plaque tool together with the IVUS, how to best treat this patient in terms of the length of the lesion, et cetera. So a nice correlation with the IVUS plaque assessment, again, with the CT plaque assessment, but bringing all the data together. And that's part of what I want to share with you is we not only look at the stenosis severity, right? Very important. But in that intermediate range, that 40 to 90%, you all know that's where it's guideline driven to send off for FFRCT. And that data helps reclassify what we do with our patients. But what I want to share with you is when you're on that continuum of risk in general, and certainly in the emergency department, you look at not only FFRCT values and the distal values to the stenosis, but also you look at the overall lesion-specific values, the myocardium at risk, which is a proximal LAD. You look at the delta FFRCT, and now the atherosclerotic plaque burden, the type, the characteristics, the amount of low attenuation plaque, again, in this case, 8%. And these factors all together better inform decision-making and who to bring to the lab and how aggressively to treat from a pharmacotherapy standpoint. So with that, we not only brought him to the lab for his PCI, but again, if you compare his before CT to after CT, you can see that we've transitioned him from a low dose of atorvastatin to maximum rosuvastatin, added ezetimibe, maximize his antihypertensive therapy, brought his LDL down initially 160s, together aggressive therapy as well as an aggressive motivated patient who began a plant-based diet and began to exercise, and he brought his LDL down to 23. And so really not, and we also added clopidogrel and kept him on that long-term after his PCI. So a nice example in the ER of how we bring all the data together. So if you really bring, my last final slide here is both in the outpatient case number 1 on the top and the inpatient setting in the bottom, both these patients had a greater than 70% stenosis. Both had extensive plaque. They were young, and they really needed aggressive therapy for long-term benefit, as you've heard this morning. But they're very different from a physiologic standpoint, right? They look similar by anatomy, but by physiology, one really patient at the top needed optimal medical therapy and all the great things you've learned about today and this week. But the patient on the bottom needed both PCI together with aggressive medical therapy. So with that, I'd like to maybe close out and let Jonathon begin the Q&A session.
Thank you, Michael. So thank you both for such excellent presentations, so thoughtful. I think bringing together those two cases was a really great way to bring us to this Q&A, and I really open it up now to the floor. I see Dr. Norgard. He's leading the Flow Promote study, doing a lot of work in the space, but also many of you here. Maybe I could, as people are deciding what questions they'd like to have answered, it's remarkable. You're sort of immersed in doing cardiac CT for a long time, and you don't appreciate one of the limitations of your reports. I've often wondered about the value of quantitative plaque to track treatment progression or stabilization and the shift between calcified or non-calcified to calcified plaque. But I think I underappreciated on my baseline report, say you have a 54-year-old, to both of you, who's already on a statin. He's diagnosed, you identify atherosclerosis, there's no stenosis. When I visually assess the amount of disease, I can provide you a calcium score, but that's removing as a surrogate measure the total plaque burden, or I can provide you a segment involvement score. But I can't really tell you where on the trajectory of their plaque stabilization are they at, and to what extent has the statin modified that trajectory, if I'm making any sense to that. In other words, you have X amount of plaque. I can't really tell you how much is calcified or not calcified on that baseline study. So how do you decide if your therapy has been inadequate or adequate as it relates to uptitration of medical therapy?
So I think one of the challenges with any coronary CT report is they're really underrepresentative of the total plaque burden or the total disease throughout the coronary tree. And that's one of the take-home lessons we learned from DECODE. And when we looked at DECODE, we also found we were completely underestimating the amount of non-calcified plaque. So if you're just looking at a coronary CT, I think the best way, are there new lesions that weren't seen, as looking at plaque progression. But I think the plaque volumes are critical to understanding that disease progression and looking at the ratios. So I typically teach people the 80-20 rule. So typically everybody should have 80% non-calcified to 20% calcium. So obviously if you're shifted more towards 90% non-calcium, it's more unstable plaque. But if you're shifting towards 30% calcium, you're stabilizing the plaque. So are you shifting all of that in the right direction? So that's where I feel like the quantitative plaque analysis is critical for looking at that progression over time. But I think we have a lot to learn there as well.
But to your point, I think even without a serial study, knowing that baseline assessment saying X amount of plaque is calcified, that may provide some insight as to the potential efficacy of the existing therapy, even in the absence of serial studies. Dr. Safian, please.
Yeah, thank you. That was a really great session. So thanks to all of you for doing that. My question relates to the use of CTA and all the adjunctive tools that we have with FFR and plaque analysis and so forth. And, should we be using these tools in asymptomatic patients? Not every asymptomatic, but particularly people who are at risk. So you look at Mike's patients who are both young, strong family history, multiple risk factors, and they came to attention because they developed symptoms. And one patient, the symptoms probably weren't cardiac, and the other one, the symptoms probably were cardiac. So, symptoms don't really seem to be a totally reliably good indicator of bad disease or not. So where are we? I mean, shouldn't we be looking at patients more in terms of their risk profile, even whether they have symptoms or not?
Well, yeah, because I manage all the patients here on this panel. My ego isn't that distorted, please. To my clinical colleagues, am I right, Dr. Gallagher?
Well, maybe I'll give you a brief, short answer and see Sarah's comments. But when patients present to us, often with symptoms, I take the opportunity of patients like the two that I shared with you. And if patients are sent to a cardiologist and they have symptoms that I think are perhaps non-cardiac, but their symptoms warranting an evaluation with the cardiologist historically that warrant a stress test over traditionally, I always take that opportunity to order a CT in that setting to make sure those symptoms are not physiologically significant and to more importantly assess early the amount of atherosclerosis that they have. So case number one was that perfect example. Turned out he had thoracic pain from playing hockey that was treated with injections from an anesthesia team. So, but question's a great one. I think there's a lot of data looking at that right now, and there's a lot of people in this room probably more capable than me to talk about that, but I think there's tens of thousands of patients being randomized into trials to answer that very question. I don't know your thoughts, Sarah.
So we've had a lot of discussions throughout the DECIDE registry, and we do have an asymptomatic arm because we know some people are getting coronary CTs who are asymptomatic. There's just no research to support doing that at this point. I think probably the most profound people that we're seeing within the DECIDE registry that are asymptomatic getting coronary CTs are those with high calcium scores that are over 400. So there is justification potentially in those to do a coronary CT because there's a higher likelihood of obstructive disease in those patients. I think looking for anginal equivalent symptoms is key: shortness of breath, dyspnea on exertion, fatigue. A lot of people are symptomatic that we don't feel are symptomatic. So I think really diving deep, do they have anginal equivalent symptoms? But also the PVD patients. We under-recognize coronary artery disease in a large proportion of our peripheral vascular disease patients. And those patients aren't able to walk or get the meds necessary to elicit symptoms sometimes, or our diabetic patients potentially. So I think there are buckets of people, preoperative testing, high calcium scores, perhaps PVD patients that have some data currently. But I think we have to learn how to use it in symptomatic patients, using that hierarchical evidence that Jonathon talked about, right? There's so much we have to learn in our symptomatic patients, and then we have to do the appropriate studies with asymptomatics.
One last question, if we could, please.
Yeah, excellent session. I have two short questions. First is, how does Heartflow FFR perform in the setting of heavy calcification? Because there's data, as your calcium score goes up, as the calcium arc goes up, the FFR doesn't predict as well as in individuals who have mild or moderate calcification. The second thing is, Sarah, in your practice, when you follow these patients in your preventative clinic, we are doing plaque analysis to get them a visual, this is your plaque, so to emphasize and make them more compliant. So do you routinely do follow-up CT plaque analysis on these patients, again, because aside from symptoms, they want to have another proof that, oh, it is getting better when I'm taking so many medications. So what's your practice? Thank you.
So maybe I'll tackle the first. Again, as with much of our cardiac CT data, as mentioned, a lot of it comes from our learnings from Denmark. And there was a nice paper published almost a decade ago as it relates to the sub-analysis of the NXT trial. Of course, the PI was Bjarne, and then published a sub-analysis as it relates to calcium. One of the keys, though, as it relates to calcium, I think we heard from Professor Achenbach earlier, is that, like with anything, image quality is fundamentally important. One can have a high calcium score with noise, one can have a high calcium score with motion, or one can have an isolated high calcium score with good vasodilation, reasonable noise properties, and absence of motion. So no test is perfect, without question, and sub-analyses of larger studies provide insight to the persisting or maintained diagnostic performance of FFR.CT. We also have excellent data from Denmark that shows that FFR.CT is prognostic beyond the calcium score out to 7 years in the advanced registry. In other words, you could have a high calcium score and a negative FFR.CT. Your heart event rate at 3 years was 1% for cardiovascular death and MI. And independent of the calcium score, abnormal FFR.CT was associated with a 5 to 7 times higher hazard for heart events. So on a personalized level, though, you have to be thoughtful. If you have a calcium score of 5,000, there's going to be boundary condition challenges. Even, I'm using words that Dr. Taylor's taught me, boundary conditions and these things. So we're clinicians, and that's one of the real opportunities for us still, is to understand that no tool is perfect and to really apply it thoughtfully in the patient that we're serving, of course.
So as far as follow-up, I tend to use symptoms to guide my follow-ups. Still to this day, rather than just the plaque. But there are a few high-risk patients, like if I see a moderate to severe stenosis, that I will do a follow-up typically in 18 to 24 months, just to ensure that we're maximizing medical therapy, that they're responding, because they're high risk for a future event. So there's no guidelines for that, but typically I do use symptoms to guide. And again, I think it reinforces compliance to patients. One of my patients, for instance, has familial hyperlipidemia that I did do a serial follow-up scan. And she's on 3 lipid-lowering drugs, and she got tired, and she was like, I just quit them over the summer. So again, seeing her plaque grow, even though we actually saw improvement in FFR.CT, actually in the side branches with her advanced treatment strategy, it forced her to be compliant again, understanding the value of the medications we were on, but she saw some progression of her disease, so that forced her to understand, yes, I need to be compliant, and yes, I now will agree to that new medication. And I think when we're looking at these new pharmaceutical agents, the plaque is going to be very informative. As we see these evolution of Lp(a) drugs, we don't know how to use them. I think that CT will help guide some of those decisions in those patients.
Well, thank you. What a great way to end the session. I want to thank again our sponsors, Heartflow, not only for creating this forum, but for the support of the Society for the last 15 years. I want to thank my colleagues. Was I right or was I right? These are really exceptional educators. Thank you both for your contributions.